the real connection was the animal vector that became part of that. And in that case, it was a cat or a feral cat. Bring it up to the 10 years, 12 years later, now we're talking about another infection that occurred related to a coronavirus. These are now beta coronavirus, another one that happened in the Middle East, also very deadly. And it was called MERS, so Middle East Respiratory Virus. So the MERS virus ended up being in the Middle East, was associated with bats, and then the vector was associated with camels. And if you can imagine, there's a huge difference between cats and camels. So there's a huge difference between the two, yet this virus was able to cause this infection, was able to transmission over to humans and then cause a major infection. Now we jump forward to what we're dealing with now. So in all aspects of this, and the theory is that there was a coronavirus. This coronavirus, and there's enough evidence to show that this coronavirus was associated with bats. So these bats ended up having this coronavirus. Now, if we look at bats, bats in general carry most, if not all, coronaviruses. They are reservoirs. So they end up having the virus, they carry it around, they don't get infected from it, and then they actually pass it to other animals. In nature, this is usually not a problem. So if you have a bat that's out there in nature and it defecates, because interesting enough, in animals, this is actually more or less a GI virus. Now in bats, it's just going to be in everything, so it didn't really matter. So usually the way it's passed is by passing through the stool. So a bat usually flies around, as long as an animal doesn't go into the bat cave, there's really not a great association. So you end up having this bat that's flying around, it poops, and then some animal would have to come across that while it's still infectious, while the UV light didn't kill it, and then end up consuming something around it and potentially getting the viral infection. You can imagine that the odds of that happening are really, 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 really low. So that doesn't happen that often in nature. If it does, it takes hundreds of years to occur, unless you're man. And unfortunately, just the way that we have a tendency to farm, and in particular in China, this becomes an issue. This is where evolution kind of takes a huge leap and a rapid step and an exponential. So things that can occur in hundreds of years can occur in years. So what happens is that in China in particular, in this little area, Wuhan City, there was a seafood market. And the seafood market not only had seafood, but it had a lot of exotic animals. And those exotic animals were put very closely together. If you put a bunch of animals closely together, there's got to be a way to make sure that they fit into these enclosed spaces. And then you also have a lot of humans that are sort of walking around. So if you have all these animals in an enclosed space, you can imagine you need to stack them up. And that's what's a term called stack farming. So what occurs is they take the smallest animal, they put it on the top, and they start putting bigger animals on the bottom. Now, the problem with this puts potentially evolutionary pressure on the viruses or even bacteria or anything else associated with this. So you can imagine that there's a stack of animals, and on the animals, you're going to put the lightest thing. In this case, it might have been a bat. So a bat, you got a cat, you may have a pig on the bottom. That's sort of where it is. This also is really important when we get things like swine flu, because that's the same vector, the same way that we can get this pressure, this evolutionary pressure to change the viruses to change. So what occurs is then you can imagine that this bat defecates, the animal below it eats its food and it's contaminated with its defecation, and then it defecates and goes from there. Interesting enough, as I mentioned, not necessarily in bats, but in other animals, the coronavirus is really a GI virus. So it causes a lot of increased virons within the GI tract, and then there's diarrhea associated with it. And diarrhea causes increased amount of virons that are there, causing an over-contamination. So let's go back to Wuhan City. So Wuhan City, you have this farming that's going on. You have animals that are exotic and restricted and banned. And what it looks like happened is that there was some sort of association with a bat. That bat was carrying the coronavirus. That coronavirus then got into animals. You can see this is where we are in this cartoon. You see we had the viruses. They ended up getting into an animal. All of a sudden, the end of December, or let's say actually even before the end of December, probably the fall, all of a sudden they noticed in China that people were getting sick. they were developing a severe respiratory illness. Initially, that respiratory illness would be under the terms of a zoonotic illness. So they were getting an infection from an animal. It wasn't human to human at that point. It wasn't person to person. It was an animal. So you would be associated with an area. Once you were associated with an area, you would end up getting sick. And they started detecting that probably in the early fall. It wasn't until the end of December when people started getting sick outside of that contact in Wuhan city. At that point, it changed from a zoonotic illness to what we call as an effect, a spillover effect. So we ended up spilling over, and this became, instead of being an animal to human, it was an animal to animal, and then it became an animal to human. Now it was a human to human illness, and this is when it becomes really tricky. So the thought is that this bat, this is called the horseshoe bat, that this bat is associated with the coronavirus and carries the coronavirus. So if you match the human virus that we have and match it back to the bat, you can find in this bat 100% match, pretty much 100%, probably 99% match between the genetic code seen in this bat versus the genetic code that is actually identified in the human virus. So that's our little guy. You can imagine, in this case, flying in nature, probably not an issue, but, and you can see a little wanted sign for this one. Please don't go out and kill bats. They're still really good. This is why I emphasize the nature. Nature is a good thing, but if we start modifying it and getting things too close together, this is when we have problems. This little guy all the way to the right of your screen, this is called a pangolin. So probably it is a endangered animal. It is also an Indian animal. So it's actually not even from China. However, this was located in the market. And when they did genetic comparison of the coronavirus that's in humans and this pangolin, which is used as Chinese medicine, it's eaten, a bunch of other things that we use it for. Scales are used for medicine. It's got a keratin scale. So there's a lot of things that are potentially used with this animal. It looked like there was at least 96% comparison between the coronavirus that are in humans and the coronavirus that is in the pangolin. So first lesson is, don't eat weird shit. So that's the first thing. So you gotta be really careful about what you're eating. And unfortunately, that's one of the ways that this could have been spread. So the pangolin is thought to be, this is still out there. There was a very nice article in Nature demonstrating that this is, the mystery is not necessarily solved, but it gives you an idea of what we're potentially dealing with, and you can see the importance of it. Now, there could be a direct route. This is bat soup. This is the same bat that I showed you. Bat soup, and this unfortunately was in the middle of the Wuhan outbreak. They were still eating bat and bat soup. So there is again, the other thing is be careful what you eat. Interesting enough, this was cooked, so it probably is less likely to be the cause. But again, you need to be really careful about what you're eating and what you're sort of spreading along. Let's go into the data. So I told you guys that when we're talking about this virus, we're talking about a new virus. And I mentioned that a couple times, a new virus. Again, the coronavirus itself isn't new. The family isn't new. We've seen the coronavirus. However, because of this mutation, and because this is a beta coronavirus, this is the first time that humans have actually seen this virus. That's a really interesting and important thing to understand. The reason is that if it's brand new to us, that means we don't have any antibodies to it. That means we can't fight it off. That's a big deal. And that explains why we're seeing what we're currently seeing, this rapid transmission of this virus that has a relatively high infectivity. And in terms of greater understanding of virology, it has a relatively low mortality associated with it. But the problem is that we don't have any immune system to fight it off. Now, even in the great pandemic of 1918, which a lot of people have been hearing about, the people who actually died from that were younger people. The reason why younger people were dying in the 1918 pandemic was because the older individuals had immunity to it. And every year that you end up getting a flu shot, essentially what's happening is you're building up memory or immune memory. So you continue to build up immune memory. And then if something bad does occur, you'll have at least some protection for it. In this case, there's no protection. Because MERS and SARS-1 was not widespread. The problem is that we never saw that as humans. So we never developed any immunity. And that becomes one of the biggest issues. So let's talk about sort of what we saw in China as our initial data, what's been confirmed in Italy, and sort of also been confirmed in the States. And this is really important to understand. And this sort of breaks down some of the hype. So 81%, and this is pretty consistent. So 81, probably higher, 81% have a mild illness. 81% of them do not have any problems whatsoever. 95% have a complete recovery. So that's really important to know. So 95% will have complete recovery from this illness. Now, there is a little bit of gap between mild and complete. So about a 14% will be put into the category of severe illness. Severe illness means that these are potentially people who are admitted to the hospital, probably the best way to define them. So they get sick enough to go to the hospital, sick enough to get the support within the hospital, but not sick enough to go to the ICU, not sick enough to go on the ventilator, etc. There's about 5% that get critically ill and will essentially need to go to the intensive care unit. Of those, about 1% need to be on ventilators. So we're not talking about really big numbers, and I'll show you sort of what comparison that is to the flu on a regular year. So based on that data, the people who are at highest risk turned out to be people who are sick, so they have chronic illness, and more importantly, it's a very age-related illness. So if you look at this data, which also seems to be confirmed, the only difference that we would add to this data, this China data, would also, it actually has to do with sex. Men in the Italian data are 70% of the mortalities in Italy are males, 30% are female. So it's actually more male predominant disease. So males, particularly older males, are at the highest risk for this illness. So when we talk about the high risk, what we're talking about is anyone who's 80 plus, they have once they contract the illness, they have a 15% mortality, almost 15% mortality. That's a big number. And that's sort of one of the biggest concerns that we have is, protecting our vulnerable population, protecting our elderly and our people with chronic comorbidity. But you can look at it, it's actually not that great either if you're 70 to 79. On this data, it's 8%. That's still a pretty big number. So if you look at probably 65 and older, anyone who's about 65 and older is about 5%. And then you can go down, it goes down a little bit lower. And as it goes down, it drops pretty drastically around the 40, 49. You see it's really closer to 0.4%. Important to know, this is also very consistent with humans who don't have immunity. It's going to affect those who are older and who have comorbidities. Let's talk a little bit about diagnosis. I'm going to spend a little bit of time on this because this is sort of the next step. This is the really important aspect of it. So this becomes really important. So let me tell you what we're doing. Let me tell you about what's happening at Griffin and what's sort of limiting what we're trying to do here. So right now at Griffin, so when we initially came out with the illness and testing for the illness, what we were using what's called PCR. PCR is a way that you can look at the genetic code of the virus and you compare it to whatever genetic code you have in your own body. So that's how you compare it. So you're looking at the genetic code and then you're comparing it to your sample, and then you're putting them together and you're seeing if there's a match. And that's how we determine if you actually are infected with COVID-19. So it's actually it's a really neat science. We're really looking at, if you think about it, we're looking at the genetic code. In this case, it's RNA. So we're looking at this RNA, this very tiny molecule. And the only way that we can look at this tiny molecule is if we put it in there and then we have to replicate it multiple times so it's actually detectable. And then we say, okay, look, it looks like we actually have this virus and we can say it's positive. Initially started at the CDC. There was a really low number that was tested for this, very low number. This is then moved to the state. Now Quest and other laboratories are currently doing it. Griffin has actually purchased a device called the Cepheid. This is the device here to your right. This is from our lab. This is Cepheid. It doesn't look all that impressive, But each one of these bays, which are 12 bays, can do little PCR, can do genetic amplification in this little spot in our lab. And you can think about it, you got to be at least a little, I mean, I'm kind of a nerd in this aspect, in the science of it, but this is pretty neat biology if you think about it, in genetics that we're doing in a laboratory. We can get a turnaround time in 45 minutes. And we are doing pretty well with the cassettes. The biggest issue that we're currently having is swabs. Interesting enough, we have this great science. We're doing okay with getting these cassettes, but unfortunately, we're having a harder time getting swabs. And it's not just sort of the cotton swabs that you sort of get. They're not like Q-tips that we can use to make life a lot easier. Each one have to be a special swab. Because you don't want it, because I mentioned it's genetic code. So anything that has any genetics associated with it can actually contaminate it. So we need special swabs. Those swabs need to be in a viral media. So I'll put my first call out. If anyone out there has any sterile swabs, that please let us know, because this is what's limiting our drive-through and our testing. And this is sort of within our area. So again, that's really important. Interesting enough, we're still moving forward with other testing. The other testing is molecular testing. Molecular testing is we have a specific code that we're looking for within that virus, and we can rapidly find that. So we rapidly have an identifier. We can find that. We can find that in 5 minutes. So we're currently waiting for this test to come right now. So we've ordered this also. It's called the Abbott ID Now. It will look for molecular code. We'll be able to do that in 5 minutes. So this would be, instead of even the 45 minutes where we have to do the nasal swab, we do the 45 minutes and then we have to wait and let it go. This is essentially a bedside swab. So we'll be able to swab, and I'm really important to say swab. So we actually need the swabs for this also. So you have to do the swab, you get a swab, and then you can actually do it right at the bedside. So that means you can come into the emergency department, or you can go almost anywhere. If we can get these out there, you go almost anywhere and you can find out if you're positive or not. These tests are very good. They work very well. The third one, which is probably the one that I'm most excited about, and I think it's going to be best for our economy, is the serology test. And there's a little thing here, this little device, it's a tiny little device. This is actually a serology test. This is called a laminar flow device. What happens with this device, this is not a swab. This is actually, the best way to run this is actually a blood test. It's very similar to a pregnancy test. Pregnancy is obviously urine. You put a little urine on there and it looks for a certain type of protein that is released when you urinate. And if you're pregnant, you'll have that protein there. In this case, it'll actually look for antibodies. So let me explain very briefly what antibodies are and what we're looking for. So every time that you get a vaccine, the reason why we give you vaccine is we give you, the human, we give you some protein, and then you end up developing a response to that protein. Your antibodies develop it. So those antibodies are either early antibodies, which are called IgMs, or they are late antibodies called IgGs. Late antibodies, the IgGs, are really important for immune defense. If you have a little bit of an IgG that's floating around your body remembers that. And then when that virus shows up, this is the best defense that you have, because that IgG basically says, look, we have a new invader, we have a new virus, we need to rapidly kill this thing. Before it even gets into a cell, we need to attack this. And that's actually what IgGs do. So that's why vaccines are really important. And that's why, we'll talk a little bit about where we are with vaccines for COVID-19. The interesting thing is, for people who have got the infection, and as you've heard, there are people who develop asymptomatic infections. So if there's people who develop infections, and as this wave goes by, then we can start to determine who's been infected and who hasn't. This is really important for basically getting back to work. If you've been infected and you now have IgG, you're essentially immune. So you cannot get that infection, nor can you transmit to anyone else. So that becomes really important to do. This is a 5-minute test. It's a finger prick. You finger prick, a drop of blood, a couple little reagents, and then it just laminar flows. The little lines will change color if it's an IgM or an IgG, and tell you if you're immune. Only works 3 to 5 days after infection. Best time to use it is usually 21 days after the initial infection. But this will give you an idea of essentially if you need to wear a mask, if you can, return to work, who's immune or who's not. The more people that are immune is actually better for us also, because it's basically like getting the vaccine. So really important thing, and this is the next step. Right now, there's only 2 on the market that are FDA approved. There are a lot of these devices that are being made. I imagine by as early as next week, you're going to see several more that are approved to be used. And it's going to be important for us in the hospital. It's going to be really important for businesses to start looking at, how are we testing to see if people are immune or not, and going from there. Interesting enough, I know I mentioned asymptomatic. Now, granted, asymptomatic is a relatively low number. You don't see a lot of people who are necessarily asymptomatic. Typically what you'll see people who develop fever, cough, shortness of breath, and depending on the age, it is going to determine how ill they get. Now, again, there's always variations because this is a biologic organism. It's a virus, and it's going into another biologic organism, us. So because of that, there are some variations associated with it. But essentially what happens is that depending on your age, you're probably going to have a worse response to this virus also. Not only do you have a higher mortality, but you also have a higher response. So what we've been seeing, and I'm making a lot of phone calls to people who are positive, what we typically see is that people who are very young have a very mild illness, and it could be deemed asymptomatic. So you may not have any symptoms at all. That's possible, but it's tough to say. Even if you're asymptomatic, the whole respiratory aspect goes away. It means you're not producing a lot of virons. But it's also important that those areas that are touched by the person who is asymptomatic are cleaned well. And this may be one of the reasons why we want to make sure that people are wearing masks, not because we're worried about airborne. What we're more worried about is getting a lot of things contaminated. And we believe that children can pick this up and spread it all around because children like to touch a lot of things and put their fingers in their mouths, and so they could potentially be carriers. We see minimal illness in children. And as a patient gets older, we end up seeing more symptoms. So usually in their teens and 20s, kind of a mild cough, flu-like illness, mild. Starting at the 40s, now you're getting a pretty significant flu-like illness. And then you get, after the 60s, you can get really sick from this. A lot of people have been describing this probably in their 40s plus as, they were fine a few minutes ago, and now they felt like they got hit by a truck. And that's sort of what we're seeing from a clinical standpoint. But it's not really a predominant thing. You hear about lack of taste, lack of smell. You hear about feeling like a truck. You hear about fevers. These are all sort of associated with this illness. What we're doing is we're focusing on the infection control. So I will tell you that hand hygiene is the most important thing we need to do. Hand hygiene is way more important than wearing masks. However, it's hard to get everybody to wash their hands all the time. So and we do know that there can be, if there's a direct contact with someone, that we know that the mask can spread it. The biggest issue with the mask is it's a lot easier to mandate because you can see a mask going across people's face. If you have a mask, then you know that you're controlling that source. So if I'm sick and I have a mask on and I end up coughing that out, so if I cough it out, it's actually going to be contained within that mask. It doesn't contaminate the fomites. But what's really important about this virus is you really need to, either you get coughed right in the face. I mean, literally you have to be like 3 feet away, either cough right in the face, or probably more importantly is that you touch a surface and then you touch your face and your mouth. That becomes, or your eyes, your nose, your mouth. You end up bringing that virus and you're bringing it up to there. That's how it goes. If you wash your hands before you got to your face and mouth, then it's a non-issue. But if you don't, then you're gonna contaminate it. One of the early concerns about wearing masks from my standpoint is that people had masks on, but most people are not used to wearing masks. And even someone like myself, who's like basically my entire career is wearing masks, it's an annoying thing to have something on your face. And when you talk, especially if I was talking now, I'd have to keep pulling it up and down. But you see everybody kind of digging at it, scratching at it, moving around. This is a bad thing because you end up touching surfaces, and then you're messing around with your mask. It becomes an issue. If everybody's wearing a mask, then the likelihood that surfaces are going to get contaminated is a lot less. So I think that's where I still say hand hygiene is key. It's a lot harder to monitor hand hygiene, but it's really a lot easier to monitor wearing a mask. So those are sort of where we are right now. Obviously, wearing masks, you don't have to worry about tissues, coughing, sneezing, because these are going to be there. And even when you're wearing a mask, it's still important to have the 3 to 6 feet spatial separations. Let's talk about the vaccines. So one of the things about this virus that should be pronounced to the community is, just the science that we see this day and age. I mean, we're talking about modifying and replicating genetic code. We're talking about, when we talk about these vaccines were pretty much made the day we knew about, within a few days of knowing about this going across the world. I mean, the vaccine was made very quickly. So we do have vaccines. In fact, we have at least 5 different vaccines that have actually been produced. The trick is that we need to make sure that the vaccine is actually safer than the illness. I mean, we don't want to be injecting people with a vaccine that they end up having worse complications than they would if they actually got the virus. So we need to be very careful about that. So developing a vaccine is one thing. It takes a lot of time, but it's not a hard process to do. The hard process is making sure that it's safe. So right now we know that at least several are in human trials to determine if it is indeed safe. Well, we know it's safe in animal models, so we know it looks like it's safe. Now it needs to go to human models. So right now we have it in human trials, and then we'll have to take it into that next level. This takes a lot of time, a lot of statistical analysis, and we want to make sure that the population is indeed safe from this. So it sounds like probably about 12 months before we have a vaccine that's there. This is really important. If you think about it, if we do a great job in preventing people from getting sick and preventing people to getting infected from this virus, that means we're going to have a lot of people who are not immune. So people who are susceptible to this virus. So if we have people who are susceptible to the virus, that means they can catch it at any time. Without a vaccine, that means there's a possibility. So the concern is that even though we do a great job at preventing people from spreading this, and we're all wearing our masks, one of the problems is that as soon as we stop wearing our mask, and there's one person with a bunch of virons or ends up getting a fomite or getting an area infected with a virus, then we can actually get these clusters and outbreaks, which is a real possibility when we start returning back to work. The treatment right now for outpatient, it's really supportive. There's been some rumors about there and some false data that's gone in there, and again, sort of outliers about the treatments. You can pretty much use anything as long as supportive. So cough medicine, Advil, Tylenol, any of those are absolutely fine to use. So that is a recommendation to use as an outpatient. For the severely ill, there are 2 medications that have been used with some success. It looks like we're definitely getting some success from them, but it's not a wonder drug. The two medications that we're using is hydroxychloroquine, which is a malaria medication, which does seem to be working, and the other one is remdesivir, which is a really interesting antiviral, which also works against Ebola and some other really scary viruses. Again, the data is okay; it looks good. The other thing that we're using is we're stopping the body from developing or overdeveloping a response to this, which can be dangerous to the body. So we're inhibiting things like interleukin. So an interleukin inhibitor could also help people recover faster. Interesting enough, we are working with the Red Cross to develop, the Red Cross is sort of developing this and collecting it. So when you develop this infection, you develop antibodies, as we talked about before. We can detect those antibodies. We can also collect those antibodies. And so with the help of the Red Cross, people who have actually got the infection and have gotten better can donate their plasma. So not their blood, but their plasma. So we can actually donate their plasma. The plasma can be treated, and then that plasma can be used for people who are really sick. And basically what we're doing is we're giving them an infusion of antibodies. So we're infusing those antibodies that will eliminate the organism as quickly as if it just showed up for the first time. And we're looking to see what kind of success we develop on that. But that is brand new because we've been seeing more and more people with this. We're able to collect that, and again, at Griffin Hospital, we'll be doing that. Let me give you a quick comparison of COVID-19 versus influenza, just so we can put this into perspective, because this is a really interesting slide. This is a slide from the New England Journal of Medicine. If you look at a moderate illness for influenza, so I'm gonna take you to the left and we're gonna move to the right and we're gonna stick to the moderates just so I don't scare you too much. So if you look at the moderate, because that's what it looks like from both sides. So you look about the population that's infected is about 20%. A lot of people get sick. I'm gonna bring you, so we don't spend tons of time on this, I'm gonna go right to the deaths, because I think this is the one that's really important. So you look at a moderate season, which was last season, there are 48,000 people who die from the flu. 48,000 people who die from the flu with a vaccine. So we have a vaccine and we still have 48,000 people who actually die. Just so we're clear. With COVID-19, it's looking like we're in the moderate category. So about 5% of the population infected. That number will probably be higher because of these patients who get mild illness. 5%. If we go right to the death, that's about 80,000. So we're looking at less than 100,000, again, without a vaccine. So when we're talking about it, we're talking about sort of a really bad flu season is really what we're talking about when we're associated with the COVID-19. So what's the difference? The biggest difference between the two is that an influenza season is 4 to 6 months. The COVID-19 season is coming in waves and lasts probably less than a month, right? It'll continue on, but when we're talking about what we're dealing with now in the peaks, we're talking about, a couple weeks to a month. And that's a huge difference. So you think about it, when you have 80,000 deaths in the US, potentially 80,000 deaths in the US, compacted into a month, that is a almost impossible feat to manage in our current healthcare setting. We can't handle that. It's just unsurmountable. So if we took some of the numbers that we were talking about in New York, so if we looked at it and we talked about my numbers that we were talking about before, and just basically on 8 million people. So if you break it down, you kind of cut it all apart and you say, okay, on a conservative number, you said based on sort of that 1% that people would be on the ventilators, that's 40,000 people that would be on the ventilators in New York. Now, thank God it was lower than that. But that's where that $40,000 persons came from. So 40,000 ventilators, that's where that number is. That's basically 1% of half of the population in New York City. And we luckily never saw that much. So again, which also kind of puts us into that moderate category. Again, 80,000 deaths is still a lot of deaths, but in comparison to sort of the influenza, it's a lot different. It gives you at least a different perspective of it. So what are we currently doing in the hospital? So in the hospital, at least when people are aerosolized or on the ventilator, we're using face shields, we're using a N95 respirator, we're using isolation gowns, and we're using a single pair of gloves. We've been able to escalate as the illness became more widespread in the community. So using a paper mask was fine at the beginning, and then not using them throughout the hospital. So we started off with, okay, we need to take a stepwise approach. So making sure people are careful. If they have a patient contact, then wearing a mask is important. All right. So we said, okay, now it's optional to have masks. Now it's mandatory to have masks. Now you need to wear a mask all the time within the hospital. That's sort of our stepwise evolution of it. We've also been able to take different areas within the hospital and make them COVID designated areas. So we have essentially 3 areas that are either respiratory or COVID related. In the emergency department, we modified our ED to make sure that we have it's actually a respiratory virus area. We made it negative pressure, and each room is negative pressure. So the whole unit is negative pressure, but each room is also negative pressure to make sure that people aren't exposing and the healthcare workers are safe. We actually had a down unit on our east wing. We were able to modify that. We were able to make it negative pressure, and that is our COVID unit. So that COVID unit is negative pressure centrally, and then each room is individually negative pressure. And I know our hospital looks a little bit like a laboratory with all the vents coming off. If you haven't seen the front of our hospital, that's why, because each one of those rooms are now negative pressure. So we've expanded our volume to 21 patients in that area. And then when we make it a COVID unit, then our staff can continue to wear this PPE the entire time. So it conserves on PPE. So we're able to wear the mask, the gloves, the gown, and the shield, we can wear that through our shift because everyone that's put on that unit is already COVID positive. So again, you can't cross-contaminate because everybody already has the infection. And then all we need to do is protect our healthcare workers. Our ICU is now considered to be a dirty unit. Same thing. Everyone within there, as soon as you walk in, gowns, gloves, mask, and goggles. And then we continue to manage the patients that are potentially there. This is a picture from our ICU. And you can see that we've actually have to conserve some of our PPE. So what we do is we have, so this was before we went completely dirty, and you can see this is the IV pole. The IV pole is outside of the room, so we're able to leave the door closed so we don't have to overexpose our staff, so they can actually manage the IV outside with proper piping. And then we have our Burrell, and then these little bags. These are ways that we can conserve. And we can conserve our PPE, in fact, our masks. So if we're using different masks for different patients, then we can actually put the PPE, we can put the mask in there, and then again, put on a fresh mask. So you can see we've made a lot of modifications. We've actually started to use some of the glass. So if you use some of the glass here, you can, with the glass here, you can actually start writing on this, so we can write to each other through that glass. So again, our staff has become very creative in how we manage our patients. I could probably keep going on for another hour, but I think I'm going to stop there. This is again, this is sort of a funny picture. So these two cars that are in the lot, this is the physician lot. Those two cars, the first one is my wife, Dr. Chasen's car. She's the pulmonary critical care doc, and the white Xterra, that's me. So it was just funny coming out and seeing that we're the two left that are here, and we've been here a lot.